Hi, everyone, and welcome to episode 129 of the Veterinary Behaviour Chat podcast. So today we're going to chat about sertraline. So I started with a couple of episodes about specific medications a few episodes ago. So if you want to kind of go back and have a listen to the episode on SSRIs versus TCAs, so tricyclic antidepressants in general, that was episode 108. Then episode 102 was fluoxetine. And then slightly later, there was also an episode on clomipramine. So today I'm kind of going to carry on that theme. And today we're going to talk about sertraline. And sertraline is an SSRI, so falls in that class of SSRIs. And obviously, there are some things that all SSRIs have in common, and that is the inhibition of the serotonin reuptake transporter, and therefore increasing serotonin levels in the synapse. So that is common to all SSRIs. However, we also need to understand that each of the SSRIs is slightly different and has their sort of own unique properties. And that's, I think, when we can start to make really informed medication choices. Because I think at the moment, there's a bit of a trend towards just giving fluoxetine to everyone. And while I think that there's, potentially nothing wrong with choosing fluoxetine for probably many behavior patients, I think that there are also some that might struggle with fluoxetine or that would just do better with a different SSRI to start off with. So that's why I thought I'd go through some of the other SSRIs and just kind of point out their differences. Of course, their similarities, but mainly their differences so that we can make more informed medication decisions. So let's chat a little bit about sertraline. So as I mentioned, sertraline has in common with all the other SSRIs that it inhibits serotonin reuptake, so reuptake into the presynaptic neuron by blocking that serotonin reuptake transporter. So we get increased concentrations of serotonin in the synapse, and that then goes on to do wonderful things sort of downstream from there. And if you're interested in finding out a little bit more about the sort of the individual steps and processes, how on a neurobiochemical level that all works, then have a look at my PSYCHOACTIVE course, because I go into real kind of deep detail about how that works. So that's what sertraline has in common with all the other SSRIs. However, there are some individual differences. The main one being that as well as inhibiting the serotonin reuptake transporter, it also inhibits, to a lesser degree, the dopamine reuptake transporter. So it inhibits dopamine reuptake, and therefore more dopamine becomes available in the synapse, which can be really useful for certain sort of scenarios where we specifically want to increase dopamine. And I'll talk about a few of those in a second. We also have sigma-1 receptor binding. That's another sort of thing that sertraline does, and we don't really know too much about it. So I wouldn't worry too much about that. The big difference in sertraline is definitely that dopamine reuptake inhibition. So we increase dopamine levels in the synapse, which can be super, super useful. So when would I reach for sertraline over fluoxetine? That would always sort of be my first question, like which SSRI, if I'm thinking SSRI, so if I have a fearful or anxious patient and I'm thinking I want to increase serotonin, which SSRI would I reach for? And there are a couple of things I think about for sertraline. And sertraline starts with an S, and a really good residency colleague of mine came up with some really nice sort of mnemonics for sertraline, other things that start with S. So I think about patients that are more shut down, so their behaviors are more shut down, that are perhaps a little bit more sensitive, that maybe have social anxiety, in general are a little bit more, I guess, soft and sensitive would be sort of the words to use. But also maybe where we have stomach, so another S, stomach issues. So where we maybe already have stomach sensitivities, maybe already poor appetite, maybe their behaviors are already somewhat inhibited, that shutdownness, because sertraline tends to be a little bit less flattening, if you like, than fluoxetine. That might be a really, really good choice to make. So those are some of the things I would think about. Now, from human psychiatry, we kind of think about sertraline, being the best SSRI for panic situations. So where I have a patient that tends to panic, bolt, run away, flee, sertraline might be a really good option there as well. A couple of other things I think about. So might be a good option for patients with underlying kidney disease or pre-existing kidney disease. Also perhaps a good option for patients with seizures, although we know that most of the SSRIs tend to be certainly much more preferable over a tricyclic antidepressant. When we have seizure patients, we absolutely always need to be kind of very mindful, but something that we could think about choosing. And then one of the areas I use sertraline in most is when I have a patient with cognitive dysfunction disorder, whether that's a dog or a cat, and where I perhaps don't want to use a monoamine oxidase inhibitor such as sertraline, because maybe we've got concurrent meds on board that are going to be prohibitive for that. But because of this dopaminergic activity that sertraline has, and because in patients with canine cognitive dysfunction, we want to increase dopamine, sertraline could be a really, really nice choice. And in fact, I've got a whole bunch of my older patients that have, either mild, moderate, or even severe canine cognitive or feline cognitive dysfunction. I have those guys on sertraline. So a couple of things to think about. It tends to, like I say, it tends to be less flattening. It tends to less reduce the appetite. It tends to be really good for those sensitive, shut down, kind of social anxiety patients. And again, that dopamine piece is really good for social anxiety, right? Dopamine is really great for increasing that desire-seeking behavior, so wanting to be more social, coming out, exploring the world more. Again, that's why, those shutdown patients might really benefit from sertraline. So those would be kind of uses. That's when I might think about sertraline over fluoxetine or paroxetine or another SSRI. What about doses? So in dogs, we would start at 0.5 mg per kg once daily, and go right up to 4 mg per kg once to twice daily. So quite a wide dose range. I tend to always kind of sit a little bit on the higher end of the dose range. So I usually sit somewhere between 2 mg per kg twice a day, even to 4 mg per kg twice a day. And there's a lot of question mark around. So if we're giving 4 milligrams per kilogram, is that the total daily dose, or can you give 4 milligrams per kilogram twice daily? And I have absolutely used 4 milligrams per kilogram twice daily. And that's been really, really successful and really effective. I've had some really great outcomes with sertraline for a number of patients. One that really jumps into my mind was my Rhodesian Ridgeback George, huge 60 kilo Rhodesian Ridgeback, very, very anxious and fearful. He's the dog that wouldn't come out of the car. So we ended up doing the consultation in the car with him and the caregiver. And he responded so well to sertraline. And he actually didn't have a huge dose. He was also the one that responded super well to pheromone products as well, to Adaptil. So he did great. So, and yeah, in general, my sort of more shut down sensitive patients do really well on sertraline. What about side effects? So as I mentioned already, I think about fewer side effects with sertraline, especially that flattening and that reduction in appetite. That can obviously also still occur. It is an SSRI, so we might get some lethargy initially, and I have seen that as well, but it's usually less marked than with an SSRI like fluoxetine. And again, less appetite changes. The two things I would probably think about is I have seen sertraline loosen the stool in dogs and cats. So if we've perhaps got a patient that's maybe prone to loose stools, that might be something I might consider, although we also then don't know whether the loose stools are kind of as a result of stress colitis, and in fact taking the anxiety away might help with that. So it's always so complex and multifactorial. And then I also think about with cats, we have to be really careful about urine retention. So if we are prescribing sertraline to a cat, I didn't say the doses for cats. If we are prescribing sertraline to a cat, then we really need to educate the caregiver about looking out for, are they still urinating? Sorry, doses. I just gave you doses for dogs, right? That 0.5 to 4 mg per kg once to twice daily. With cats, we would usually start at 0.25 mg per kg once a day, up to about 1.5 mg per kg once a day. So I don't usually go to twice daily dosing in cats. Cats tend to metabolize differently. Again, if you want more information on that, there's a piece on pharmacokinetics and pharmacodynamics in the psychoactive course. And I talk specifically about cats and their sort of slight differences in metabolization. So once a day dose usually for cats. Sorry, I missed that. Right, back to the side effects. So remember the urine retention in cats. I mean, all SSRIs and tricyclic antidepressants would, I would be thinking about urine retention, but sertraline is definitely up there. And then contraindications. So if you're changing from a monoamine oxidase inhibitor or to a monoamine oxidase inhibitor, we want to make sure we always have at least a 2-week washout period. So that's kind of a particularity of all SSRIs. Remember, fluoxetine is even longer than that. It's 4 weeks washout because of the long half-life of fluoxetine. And then, as I just mentioned, I'd always be a little bit careful with cats that might have either kidney disease or a history of bladder disease, maybe just because of that urine retention piece. Patients prone to loose stool, as I mentioned. And then we always need to be cautious about any other medication interactions, that if the patient is on any other chronic medication, we always need to think about that. So that's kind of my summary, a little bit of sertraline. I think it's a super, super useful medication. I use it a lot. It's probably my second most commonly used SSRI. And yeah, I kind of have those essentially 2 big groups, right? Like if they're very kind of active and frantic and, very sort of fast moving, and then fluoxetine, I think, is one that I would go to. Whereas if I have these more shut down, sensitive, socially shut down or socially a little bit inhibited patients, or I have, sensitive GI tract, or I have an older patient where we've got cognitive dysfunction either on its own or in combination, with anxiety, then sertraline, I think, is a good option. I have to be honest, I haven't used it a lot in cats. I've used it in a couple and it's worked really well. Just remember that once a day dosing in cats. Dogs, I tend to find it needs twice a day dosing. So in my experience, we may start with once a day, but we kind of usually end up with twice a day dosing. All right. I hope you have found that useful. Remember, the episodes I mentioned to you earlier, 108 is SSRIs versus TCAs, 102 is fluoxetine. I'm going to be recording another episode on paroxetine, so that'll come up in a couple of weeks. If you want to learn more about psychopharmacology, then you have to check out my psychoactive course. It's such a cool course, and it's kind of one of my favorite things to do in the world, is kind of host that course and then be part of the quarterly live group Zoom calls, the Q&A calls that we do that are just so cool. And yeah, so I will leave the link to Psychoactive in the show notes. And then I also just want to tell you about my membership, which is the Behaviour Case Collective, where we once a month do a live deep dive into one of my real life cases. And we chat through like the whole approach of working through a case with everything that's involved, from, kind of problem lists and caregiver challenges and treatment plans and, which psychopharmaceutical agent to choose if we're choosing one. Obviously, not every case needs psychopharmacology. Yeah, so that might be also of interest to you if you've enjoyed this episode. So I look forward to seeing you next week. Thank you very much for tuning in, and I will catch you next week. Bye for now.